All right, let's go back to Q&A.
Hi, Joe Thompson, member of the Standing Committee from Arkansas. Great presentations by the three of you and the fourth that left. I have a question in the framework of today's and tomorrow's conference, which really it's, if you could wave a magic wand, how would you accelerate the breadth of your program, not necessarily under your control, but in the number and the reach into lower income communities and communities of color? Because we're about accelerating progress. You're demonstrating success in the umbrella that you have, but how would we take it to scale? And how would we make sure that as we go to scale, we're reaching into those communities that have the greatest need? If you have trouble with that, start here. Your colleagues on both extremes, what's the most extreme reaction, negative and positive, of your colleagues to the programs you've had? And that may give us bumpers to think about how to get to scale in the middle.
I can think of, and this makes me think about, the sustainability issue, and I think it's not dissimilar for an individual or a patient who's working to, make healthy lifestyle changes, and an organization like a school. And at some point, you cross a threshold where it doesn't become a burden to do that healthy diet or that physical activity or that workout or something. It becomes a joy because it feels good and it gets you good things, and you know that and recognize that. And so when I'm thinking about schools, the one school that I've worked with the most, they've passed that threshold as an organization. So they have this programming embedded, and they've added to it, and they've made it their own. But now another school has an interest in doing it, but they're not yet at that point. So I think, it's almost like, so what does it take? Well, it takes them to have that experience, and hopefully it's a successful and positive experience. So, and that takes at least some resources to get to that point, to help them, support them to the point where they want to do it on their own. So, I'm thinking about, how to help them get to that point, and it takes at least some, modest resources in the form of a research grant or a service grant or something like that to help them to where they think, oh, we like this, we can do this, we're going to find additional ways to do it.
And I would say, I would add to that, because I think that's kind of how I would respond. But I think that you have to identify champions. And I think that's what you're speaking about, because if there's no team or no individual who's really behind it, it won't happen. It could easily die. As Pat kind of mentioned, it's like that person who always brings up instant recess and makes it part of the meeting or part of the conferences that we go to, or somehow incorporates it and makes it part of what we do. And so you have to identify champions. And I think that's how we get it probably spread along with everything else she mentioned in terms of funding and experience.
I'm not sure we're going to accelerate progress in the treatment of obesity without some fundamental changes to the whole medical system. And that's why I stress the importance of undergraduate education aimed at nurses, dietitians, medical students, physician assistants, that begins with just training people to use the right language to open the conversation. And because, as your data nicely showed, people who have obesity, are the least likely to respond to the kinds of interventions you're describing. And that's not an uncommon experience. That's true of all the school-based interventions. It's those people with modest in the overweight category that move into the healthy weight. It's not the obese group who's moving into the overweight group. So I think we have a long slog ahead of us, but what I'm hoping is that the convergence around the recognition that chronic care is not going to respond to the classic treatment paradigms, and in conjunction with the Affordable Care Act, which is going to change the payment delivery structure, that we may have a shot at beginning to insert changes in the medical system that will then drive medical education in terms of qualifications.
If I had a magic wand, I would wave it to try and encourage physicians and other healthcare providers to listen to other voices, the patients, to You know, I can't make a prescription for a program, you know, that's exactly like mine that's going to work in Southeast DC. It's, you know, different people, different population. But I think, you know, if you do have those champions that you can identify on your staff, and you engage with patients and listen to them and hear from them, often they know things that we don't know. And so I think a dose of humility will help us.
Well said.
Hi there, my name is Makani Temba. I'm with the Communities Creating Healthy Environments, which is a national program office of Robert Wood Johnson Foundation. And actually my question is for you, Bill. We have a number of grantees, actually one of the few, quiet as it's kept, working on breastfeeding policy. And it's a huge and important issue, not a lot of attention. And all of these groups actually happen to be African American organizations. 2 are in the Southeast. And it's been a struggle to work with hospital policies to create the space to be breastfeeding supportive. So as you're thinking about the strategies, the recommendations, I don't know where advocacy comes in, what kind of ways you're thinking about helping hospitals even create the policies before we even get to the provider. You know, because policies create the environment. So I'm just curious about your thoughts on that.
Yeah, I have to confess that I'm somewhat naive about how to implement Babyfriendly. I know that in Grady Memorial Hospital in Atlanta, the biggest obstacle is the head of maternity care, who's opposed to breastfeeding. So you can't, despite the best efforts of a lot of people, you're banging your head against a woman who's inflexible. So I think that the case that the more general case that we need to make, and I think baby-friendly hospitals fit within it, is that hospitals need to be the friendliest workplace on the planet, the healthiest workplace on the planet. Not only means restructuring what we're serving in our cafeterias, but it also means promoting healthy practices within the hospital, like Baby-Friendly. I'm not sure that tactic has been pursued. It certainly, in North Carolina, seems to be an effective strategy with respect to changing cafeteria offerings, and I think they're now beginning to move into breastfeeding promotion. The other question, you know, Ryan may be the guy here. Can you generate a critical mass of provider support from the federally qualified health centers that use those hospitals to really push them around breastfeeding? Because there's this disconnect between the obstetrician, who often doesn't promote breastfeeding, and the pediatrician who does. And maybe the place that can be joined, and Ryan, you should comment on this, is at the health center level.
That's a big softball of a question. Thank you. I think that community health centers are a wonderful platform to engage in. In part, we see all ages of patients. You know, many of our patients are of low income. Currently, the 1,200 or so community health centers around the U.S., federally qualified health centers, I think see around 20 million patients a year. With the Affordable Care Act, that should shoot up to 40 million potentially in the coming years. And I think community health centers and federally qualified health centers represent a great potential opportunity. They know their communities. You know, they are the communities. Who works in a community health center? You know, where I work, it's people, you know, it's family members, it's friends of our patients. They live with our, you know, they know our patients. You know, I learn a ton from our staff. So I think that 40 million, you know, potential patients and the voice that represents, if we could
So what
speak together.
What influence do you have on hospitals that deliver your patients?
That's a good question. We have a number of hospitals, primarily at the health center where I work. Washington Hospital Center is probably the most common place. Howard University Hospital is another place. And I would say our influence currently is not huge, but you know, I think that it could definitely be greater if we were to point out, how many patients that we take care of that they deliver.
So Makani, maybe the connection is through the health centers in Southeast that Ryan can put you on to.
I just want to say, just as a quick follow-up, that actually these groups are organizing with the health centers and the clinics.
Okay.
And, but a lot of folks are having babies in hospitals. So part of what I guess I'm encouraging us to think about or grapple with is maybe we could figure out what our strategy is, because the hospital boards, because there's a ground level advocacy around it, but and also there's a tendency to not look at adults, right, in this process. And breastfeeding, it kind of requires adult participation.
Yeah, we've been taught that in medical school.
I wanted to add, can I add something?
Go ahead.
This? Also, in terms of breastfeeding in California, we've gotten a lot of movement, and that's through a lot of networking and coalition building. And WIC has definitely been a part of that. And I just want to mention that early on, what we did in a very diplomatic way, some of my colleagues were more involved than I was, but what I would comment on is that we have August that we recognize as our breastfeeding month. And so what we would do is we would survey our participants in terms of their experiences with hospitals, and then we would feed that information back to the hospitals. Initially, they were like, oh, what's this, But then now, several years later, they look forward to the information and how they're doing. And so we have definitely come a long way in terms of strengthening and building coalitions around this area and getting the dialogue going, because we had experiences where we would do all this work and have a WIC participant geared up to breastfeed. They go to the hospital, and then it would be all undone. And so we weren't the full picture, and we knew we needed partnerships with the hospitals. So this coalition building and being strong allies, providing the training and things like that. So now they see us as their best friends. We're BFFs.
We've managed to push up to and beyond the time that was allotted, and so we're going to not for the whole session. So we're going to go. I apologize to those of you who are waiting to ask questions in the Q&A. There's two other persons who are going to do public statements, and if y'all would make your way to the microphones, that would be fabulous. Lizelle Loy with the Bipartisan Policy Center is going to make a statement. And then Nicole Keith is going to also comment. Both are going to comment on panel 4.